In this video section, we will discuss about the internal hernias. So, what is the definition of the internal hernia? Internal hernia refers to the protrusion of internal organs through a weak abdominal tissue wall, and internal hernias most commonly involve the intestinal bowel loops and cannot be visualized externally. In the external hernias, in contrast, can be seen on the outside of the body, often as a bulge under the skin. So here the eight main types of internal hernias which are categorized where the hernia occurs. So these include paraduodenal hernia, which is congenital disorder resulting in a herniation near the first part of small intestine, for example duodenum. Foramen of Winslow hernia, the movement of intestines into a channel that divides two parts of the abdomen. Pericecal hernia, a defect in a tissue attached to the large intestine, and sigmoid mesocolon hernia is that herniation through tissue attached to the last portion of the large intestine. And transmesenteric hernia is that hernia impacting layers of the tissue in the abdomen. And transomental hernia, a hernia affecting the tissue covering abdominal organs. And supravesical and pelvic hernias, like the hernia that most commonly involve the tissue that attach the uterus to the pelvis. So clinical manifestations depends on like acute obstruction of the small bowel loops that develops through the normal or abnormal apertures. So internal hernias not infrequently self-resolve, making imaging at the time of the symptoms like vitals. So physical examinations clinically, these hernias present as described with no distinctive or characteristic findings on history or the physical examination. If the patient has no evidence of obstruction, these hernias can be diagnosed with a post-evacuation barium enema. Radiographs which will show circulated ileal lobes occupying the left lower quadrant and elevation and displacement of the sigmoid colon to the right. So symptoms of internal hernia vary based on the type and severity of the hernia. In mild cases, usually not symptoms appears. In the more severe cases, symptoms could be like mild abdominal discomfort or severe abdominal pain, and individuals may also experience vomiting, nausea, and constipation and abdominal tenderness. So, what is the cause? Causes are like can occur when there is a weakness in a tissue wall that allows internal content to push against it and create a bulge in the lining. This weakness can occasionally be due to the birth defect that impact the abdominal wall, causing individual to be more prone to the developing internal hernia. Additionally, the internal hernia can be acquired after trauma, inflammation, or surgery to the abdomen, and surgeries that may result in internal hernia include liver transplant and gastric bypass surgery, a weight loss procedure that creates a small pouch within the stomach. In addition, the raised intra-abdominal pressure can increase the risk of the developing internal hernia. So circumstances that raise the pressure inside the abdominal cavity include pregnancy, chronic cough, fluid buildup, heavy lifting, and straining while defecation. These are the risk factors for the hernias. So next is the classifications like left and right paraduodenal hernias, which is the most common, approximately 55%, and the lesser sac, which is also known as the foramen of the Winslow, and the pericecal hernia and the sigmoid mesocolon hernia, small bowel mesentery internal hernia, and transomental hernia, and supravesical, and the pelvic and the falciform and the internal hernia due to the gastric bypass surgery. So here the left and right paraduodenal hernia, although uncommon, have classically been the most common type of the internal hernia. However, the incidence of the post-operative internal hernia has been increasingly uh, recently. The two most types, the left and right paraduodenal hernia, involve the small bowel herniating through a congenital opening in the mesenteries. These internal hernias may result in a closed loop bowel obstructions. So here you can see that there is obstructions with the laparoscopic finding on the left side of the left paraduodenal hernia. The arrow indicate the inferior mesenteric vein, and the intestinal forceps are inserted into what turns out to be left paraduodenal hernia fossa of Lanzer's. So left paraduodenal hernia, the more common of the to apparaturian hernias, which is 75%, and here the fossa of the Lanzard herniates, and the congenital failure of the fusion of the descending colon mesentery to the peritoneum in the left lower quadrant. So right paradural hernia, which is less common and 25%, and the small bowel herniate through the fossa of Valdier, a congenital failure fusion of the ascending colon mesentery to the peritoneum in the right lower quadrant, and its association with the small bowel malrotation. So next, the radiographic features. In the left paradural hernia, cluster of small bowel loops in the left inferior pararenal space, and the cluster of small bowel loops is behind the inferior mesenteric vein and behind the ascending left colic artery. But in the right paraduodenal hernia, cluster of small bowel loops is inferior to third portion of the duodenum, and cluster of small bowel loops is behind the superior mesenteric vein and the superior mesenteric artery and the right colic vein. So here the radiographic features. Here we can see the inferior mesenteric vein, and lesser sac hernia is the hernia is that type of the internal hernia where the abdominal content protrude through the foramen of Winslow. Hence, they are also known as the foramen of the Winslow hernia. So here the images of the findings during the laparotomy. 200 centimeter segment of the small intestine protruded from the lesser retro gastric curvature of the stomach to a defected lesser omentum, and the second this figure, a defected a lesser omentum of the approximately 3 by 4 centimeter in size was visualized. So next is radiographic features. In the CT scan, the mesenteric fat and the vessels posterior to portal vein and common bile duct and the hepatic artery and anterior to the inferior vena cava. In the mesenteric vessels passing into the lesser sac via the foramen of the Winslow. Gas are the fluid in the lesser sac with the bird beak signed towards the foramen of the Winslow and abnormal cecal position. So here you can see that there the cecum and the stretched main portal vein here. So next is the pericecal hernia. Pericecal hernia is a rare type which further gives the four subtypes: ileocolic, retrocecal, and ileocecal, and the pericecal of the herniation occur in the pericecal fossa, which is located behind the cecum and ascending colon, and is limited by the parietal cecal fold outward and the mesenteric cecal fold inward. It is due to the acquired the congenital defect in the cecal mesentery, and the retrocecal hernia is the most common subtype caused by the herniation of the ileal loops through a defect in the cecal mesentery and right paracolic gutter. So here you can see that pericecal internal hernia through the avascular space of the travis, and the ileocolic artery and the right colon and the small bowel. And radiographic features like fluoroscopy, which delayed the radiographs series of the small bowel or a barium enema examination, may show retrograde of pacification of the terminal ileum. In the CT scans can often the confidently diagnosed as a cluster of small bowels, usually ileal part, and the located posteriorly and a little laterally to the normal cecum, and occasionally extending into the right paracolic gutter. And in addition, beaking appearance at the entrance of the hernia and a dilated afferent small bowel loop and the collapsed efferent loop in the transition zone may be seen. There might be evidence of the small bowel obstruction and mass effect displacing the cecum entirely and the medially. So here the radiographic features you can see by the CT scan. So next is this sigmoid mesocolon hernia, which is also known as the intersigmoid hernia. So occurs when small bowel loops protrude into the peritoneal pocket and formed between two adjacent sigmoid segments and their mesentery. So here you can see sigmoid mesocolon hernia. This is the radiographic feature. And next is the small bowel mesentery internal hernia. Small bowel mesentery internal hernia, a form of the internal bowel herniations involving protrusion of the viscera through the defect in the peritoneum or the bowel mesentery. This type of the internal herniation is more often seen in the neonates than in adults. So here you can see The small bowel mesentery internal hernia. So what are the radiographic features? So in the CT scan, small bowel internal mesenteric hernia manifest as the small bowel. So proximal small bowel dilation and the abrupt change in the caliber at the level of the mesenteric defect. In the mesenteric stranding sign is often associated. The mesenteric vascular pedicle can be engorged or stretched. In transmesenteric small bowel internal hernia do not typically show a sac-like cluster of the vessels like a paraduodenal internal hernia. In differentiation between transmesenteric internal hernia and the small bowel obstruction from other causes can sometimes be difficult. But in the intramesenteric small bowel internal hernia may appear sac-like with the anterior and superior displacement of the superior mesenteric artery. So here you can see the radiographic, and that is the exit and that's the entrance. So supravesical hernias, a type of abdominal hernia in which the viscera protrude through the supravesical fossa. Laxity with the failure of the transversalis fascia and the transversus abdominis muscle are the main causes of the supravesical hernia in the virgin abdomens. The supravesical hernias are divided into two types based on the anatomical location of the hernial sac. So external supravesical hernia and internal supravesical hernia. In the external, the hernial sac remains above the pelvic floor and protrude through the anterior abdominal wall. But in the internal, hernia sac goes downwards in the paravesical space. So here is supravesical hernias. So you can see here the protrusion of fossa supravesical. So next radiographic feature you can see, and so next pelvic internal hernia. It is the broad ligament hernia, which is type of the internal hernia in which small bowel passes through the congenital or acquired defect in the broad ligament, and the classification of the broad ligament hernia proposed by the Seeley et al. And based on the defect's anatomical location. So here the three types: the type 1 defect through the entire broad ligament, and the type 2 defect through the mesovarium and the mesosalpinx, which is above the round ligament. In the type 3, the defect through the mesoligamentum carries between broad and the round ligaments. So here the 5 centimeter defect of the broad ligament between the round ligament and the left adnexa in a 35-year-old woman with obstruction of the small bowel caused by the internal herniations. So here the second figure, the illustration of the broad ligament showing the location of the associated defect. So FT is for the fallopian tube and the OV is ovary, and the RL is the round ligament and UT for the uterus. So next, the radiographic features. The CT scan features are those of the pelvic small bowel closed loop obstruction, small bowel dilatation, and the pelvic free fluid in the double transition point in the pelvic location, which is lateral to the uterus. So here the radiographic features. So next is the falciform ligament hernia. The falciform ligament hernia is the rare type, so which is occurred through a defect in the falciform ligament, require the presence of the abnormally patent orifice in the falciform ligament and requiring both layers of the peritoneal folds which compose the ligament, and the etiology of the defect may be congenital, traumatic, or iatrogenic. So the latter, the primarily due to the injury accrued during the laparoscopic surgery, hence the epidemiologic associations. So most herniations involve the small bowel, but herniation of the omentum and the colon have been described. So here you can see the falciform ligament hernia. Next, the radiographic features. CT scan the falciform ligament hernia should be considered when a fluid-filled curvilinear dilated bowel loop is identified just anterior inferior to the liver, and the round ligament marks the inferior most extent of the falciform ligament and may be used as a landmark. The accompanying obliterated falciform artery and the paraumbilical veins travel along this course as well, but are the seldom visible. So hernia has not been observed to result in the sac-like clustering of the small bowel loops characteristic, for example, a paraduodenal internal hernia. So here the radiographic features. So what is the diagnosis? Diagnosis, in order to diagnose an internal hernia through medical history and the physical examination must likely be performed. Since internal hernia are not visible externally, they may require imaging studies in order to visualized, and the computerized tomography scans are frequently used to diagnose internal hernia, but X-ray can also be used when a CT scan is unavailable. In some cases, laparoscopy, which is a minimally invasive surgical procedure, may be required to determine the severity of the hernia. It is important to promptly diagnose internal hernia due to the increased risk of the developing small bowel obstruction, which refer to the blockage of the small intestine that can result in life-threatening and the complication if left untreated. In some cases, external hernia can also result in other complications such as the loss of the blood supply to the uh, supply supply to the surrounding tissues, strangulation, or the bladder compressions. So what is the treatment of the internal hernias? It depends on the severity. In some cases, internal hernia can resolve itself with a conservative management, and including increased fluid intake and adequate bowel rest by the restricting food consumption. In other situations, surgery may be required, laparoscopic, a thin lighted scope called a laparoscope is inserted through the incision, and the instruments to repair the hernia are inserted through the other small incision in the lower abdomen. The procedure involves the reduction of incarcerated bowel and the clear of the defect. Any non-viable bowel must be resected. That's it.